Thank you very much, Joe and Bernard, for inviting me to present here. So I'm based at academic rheumatologist based in London, and let me. How do I move the slides on?
It should be working.
Perfect. So sorry about that. So and I've been asked to give an overview, really, where we are with synovial biopsy, give a historical perspective, have a look through the different techniques that are available to sample synovial tissue, go through our major research outcomes where synovial tissue analysis has led, and also look a little bit to the future as well. So I probably don't need to remind all those who have attended this synovial biopsy course that the major indications and use of synovial biopsy is both within routine clinical care, particularly for the refinement of a diagnosis of a patient with monoarthritis, but also, and importantly, and one of the main reasons that we're gathered here today, for research applications. And when we think about clinical diagnosis and the use of synovial biopsy, we think about it in three main areas, really. So to differentiate inflammation from infection in particular, and where I work in East London, that's a particularly frequent presentation of, for example, somebody with tuberculous synovitis, but also differentiating tumours such as PVNS, which is shown centrally here. But one of the things that we have not moved towards is the routine application of synovial tissue analysis to differentiate between different inflammatory arthritides. And I'm not going to talk any more about clinical diagnosis because I know Antonio Manzo's talking about that tomorrow. So I'm sure all of those who've written any sort of PhD thesis on rheumatoid arthritis will have quoted the first recognition of rheumatoid arthritis as primary asthenic gout by Beauvoir in 1800, and the recognition of this distinct disease by Alfred Garrod in 1859. And really, since that recognition, there's been a quest to understand disease pathogenesis and to access synovial tissue, in particular to better understand the pathogenesis of the disease, but also more recently to predict outcome and also response to therapeutic intervention. But most of the early studies, dating back to the turn of the last century, were hampered because most of the synovial tissue was from post-mortem samples at very end-stage disease. Arthroplasty was first introduced around the 1930s, and that did give some access, and in particular to synovial tissue originating from the hip joint. But there was a big push to see if any minimally invasive techniques could be developed. And Forestier in 1932 did report on this adaptation of a dental nerve extractor, which could apparently sample synovial tissue. But all sorts of references to that are sort of removed because he never actually reported his results. So I don't think the dental nerve extractor ever made it past teeth. And so there was a big lull really in the technique development between the 30s and between 1952, when this needle biopsy using a large core needle was reported with great success. Actually, it always the reports, the initial reports of this, were that it would very successfully sample synovial tissue. The problem was that nobody liked doing it because it caused enormous tissue damage and required a large incision, so the patients wouldn't tolerate it. So although we got synovial tissue, it was never widely picked up. And as Doug's already mentioned, one of the great advances was the development of the Parker-Pearson needle, which was around the early 60s. And this was a 14-gauge needle which could be passed under local anaesthetic into small and large joints of patients with active arthritis. And all the reports of it gave really good success rates and relatively good tolerability from patients of sampling synovial tissue. And this really paved the way for the early identification of what was going on within the synovial tissue in patients who were alive and had rheumatoid arthritis. Arthroscopy was then developed around the 1960s, but again this was with large bore arthroscopes, generally under general anaesthetic. And so again there was a big lull until the mid-90s when needle arthroscopy was picked up by rheumatologists, a technique that could be used under local anaesthetic, was very well tolerated. And again that gave us a really good access to synovial tissue, was very successful in sampling it. And then there was a gap until a couple of years later when ultrasound synovial guided biopsy was in the early stages of development. And really, through all this time, despite the challenges in accessing synovial tissue, by the late 1950s, and this publications from the Journal of Chronic Diseases, which now is not in publication anymore, but this was one of the first reports of exactly what was going on within rheumatoid synovial tissue, and recognised the panos, the erosion of the cartilage, and the dense immune cell infiltrate. And it was from this, this first recognition of this inflammatory infiltrate, and the fact that when scientists looked at different patients, they saw different patterns of immune cell infiltrate, that the first concept of whether we could refine the diagnosis and whether patients with rheumatoid were not all the same, and whether we could refine that diagnosis based on the synovial tissue was introduced. And the three main areas of research into inflammatory arthritis from synovial tissue are really looking at disease pathogenesis, and there are many areas which are still unknown at the moment, disease outcome and predicting prognosis, and also therapeutic response. So now in 2018, we're really left with four main techniques to acquire synovial tissue. Needle arthroscopy, which can be performed under general or local anaesthetic. Blind needle biopsy is also relatively still well used with a Parker-Pearson needle. And then two adaptations of the ultrasound guided technique, both using a quick core needle, which is shown here, and a portal and forceps approach. But one of the main challenges when we think about all these different techniques, particularly within a clinical trial setting, is selection of which one is the best for our clinical trial protocol. And this is particularly important when we think about the considerations we have before designing a protocol for patients that are recruited to clinical trials. In particular, what are we going to do with the tissue? So is it all for histological analysis? Do we want transcriptomic profiling? Do we want large volumes of tissue so we can look at proteomics? So those considerations have to be thought of before clinical trial protocols are designed. We also have to think about whether serial biopsies are required. So do we want to look at the synovial tissue after a patient has been given a therapeutic intervention when the synovitis is much resolved? And it may make it difficult with some techniques to access that very low level synovial tissue. We also want to think about whether we want to include patients with large and with small joints. And also the acceptability, not just to the rheumatologist or the radiologist that's performing the procedure, but also tolerability for patients as well. So arthroscopy has been the gold standard approach for sampling synovial tissue, and that's been for some years now, and that's because of quite extensive data that's been published, particularly, and I give two examples here, but particularly this sort of seminal paper, which is frequently quoted, which was a paper that Doug Veal was an author on, and reported on the outcomes, particularly the safety of rheumatologists that were performing arthroscopy. There was also a large series looking at tolerability and success of the procedure. And coupled with this, there was also some data, again, a multi-centre collaboration led by Paul Peter Tack, which demonstrated that although there was a correlation between the number of lining layer macrophages and T cells, when we looked at sublining macrophage infiltration in patients who'd had a blind needle biopsy compared to an arthroscopy, there wasn't an exact correlation, which pushed investigators at that time towards more towards using arthroscopy, quite understandably. And these sorts of considerations were important. So when the first reports of ultrasound-guided synovial biopsy were introduced, initially using a needle technique by Bilsma, and following that an adaptation using the portal and forceps. So were these new minimally invasive ultrasound-guided techniques able to sample synovial tissue to the same degree as arthroscopy, and would we be able to get a representative view of the joint using these minimally invasive techniques? And one of the first authors to report on this was Carlo Schiré from, at the time, in Pavia, who looked at this using ultrasound-guided portal forceps and compared them to synovial tissue, which was obtained following arthroplasty or synovectomy. And what the authors did was look at synovial tissue that was obtained from these arthroplastic or synovectomy specimens and compared the variance in patients that had had synovial, ultrasound-guided synovial biopsy using portal and forceps. And what they determined was that if you looked at a minimum area of 2.5 millimetres, you were able to reduce the variance of infiltration of T cells, B cells, and sublining macrophages, as long as you looked at a minimum of 8 tissue sections. So a random area from 8 tissue sections of 2.5 millimetres gave you a representative image of the whole joint. And they could do that because they were also looking at these synovial tissue specimens from arthroplastic joints. One of the problems, though, is that using the portal and forceps approach is somewhat different, and I'm not going to go into the technicalities of this because Andrew's following me and he's talking about these techniques in more detail. But portal and forceps approach is different to blind needle approach using ultrasound-guided biopsy. And although this is a paper that Stephen Kelly from our group published in Annals in 2015, and what he demonstrated using this quick core needle and ultrasound guidance in both large and small joints was that we could get a good quality synovial tissue and good transcriptomic data. But what was missing from that was a comparison, a direct comparison with our gold standard of arthroscopic biopsy. And so it remained, and this is an extract from the OMRAC Special Interest Group in 2016, which has sort of stood till now, hasn't really changed, but arthroscopic sampling is preferable still for serial biopsy in proof of concept clinical trials. So still at the moment, still viewed as a gold standard. And that's because until recently, really, we haven't had these comparative studies. And one of the way forward for this, and this is a publication summarising really a roadmap that was developed at the 2014 OMRAC meeting of the Synovitis study group of areas that would be important to define and validate these minimally invasive ultrasound-guided procedures. And at the top of this was, are we getting enough synovial tissue, and are we getting enough synovial tissue to look for histological parameters, but also to do transcriptomic experiments, so is the RNA yield of adequate quality. And this is important in particular because previously what had been demonstrated from arthroscopic samples was that if we were to get a representative view of the joint, we needed to look at least 6 synovial biopsies, and this was true as shown here for anyway, true for immunohistochemical parameters as well as gene expression data. So again, this data stood, so 6 synovial biopsies were required if we were to get a representative image of the joint, and that should be a minimum standard for clinical trial protocols. But this was data that was taken from large joints and had not been looked at in small joints. So one of the areas we began to look at, and this was a collaborative effort with our colleagues in Pavia, and somewhat replicating the Carlos Schiré paper, looking at a comparison between ultrasound-guided needle biopsy samples, and again these arthroplastic samples and synovectomy samples, where we could get within these arthroplastic and synovectomy samples a real representation of the whole joint. And what we demonstrated actually was that in small joints, and this was a cohort of patients all going small joint biopsy, was actually you probably only needed to look at 4 biopsies rather than 6, because the joint's much smaller. And this applied for a number of histological parameters. We also looked at this paper, within this paper, to see when you're biopsying small joints, what determines success. And not surprisingly, baseline ultrasound synovial thickening, the higher the level of synovial thickening, the more likely you were to get a successful outcome with a higher number of graded specimens. And the same rang true as well for RNA yield. So if you've got higher levels of synovial thickening, you've got higher levels of total RNA. Sorry, there we go. Oops. So, sorry, these boxes aren't coming out quite right. So now moving on to the sublining macrophage number versus clinical response. There you go. So embedded within that paper, in addition, was an evaluation of an important factor, which is part of the OMERAC filter, looking at whether samples that were accessed using a minimally invasive ultrasound-guided approach were able to determine active versus inactive disease using our validated biomarker for that, which was sublining macrophage number. And as you can see from these patients here, that were treated with a TNF inhibitor, there was a really good correlation between change in the semi-quantitative CD68 sublining number against fall in DAS28, so demonstrating an internal validation of this data. So, the next thing of critical importance, of course, when we're thinking about translating these techniques to routine clinical care, and particularly with the background of arthroscopy, which we know is pretty acceptable to patients, is how acceptable are these minimally invasive? We all go around saying patients love it, you know, it's just a little rub with an ultrasound machine and a very small needle to take out a tiny bit of tissue. But actually, do they? And have we ever asked them? What we did, this is back to Stephen Kelly's paper from Annals from 2015, and in this paper of 93 patients, patients were asked before and after the biopsy about pain scores, amongst others, and also whether they were likely or not to go on to have another biopsy. And as you can see, there was very little change. The joints didn't seem to get worse after the biopsy, and the vast majority of patients were agreeable to having a synovial biopsy, repeat synovial biopsy. And in this study, this was from our PEAK, which is an early arthritis intervention study, 90% of patients went on to have a second biopsy. So this data was good. And it's certainly in our centre, patients tolerated it well and were very happy to have a repeat biopsy. But one of the issues was that there was no comparative data. And this is data that has recently been put together by Søren Andreas Just from Denmark. And actually Andrew Filer is going to go through this in more detail. But just to say, this is, again, a European synovitis study group-led initiative with data collected from over 5 centres looking at safety and also patient-reported outcomes. Is the procedure well tolerated, and evaluating these different techniques. So looking at a cohort of arthroscopic patients against the 2 different ultrasound guided methods. And essentially, I'll let Andrew go over it in more detail, but essentially there's no real difference in tolerability and no safety signals that were picked up as in terms of AEs. So, finally, when we think about introducing these techniques, and I suppose one of the reasons for gathering everybody together at this Congress is to think about our training and how we encourage new participants to take up the technique. And one of the outcomes defined at OMERACT was looking at defining a learning curve for new operators for ultrasound guided biopsy. And this learning curve and training courses are already obviously very well defined for trainees who are undergoing arthroscopic procedures, but less so for these ultrasound guided. And Alexandra Nerviani, who's one of our clinical fellows within our department, has been looking at this locally within our centre. We've performed over 700 biopsies in the last 10 years, so she's got a good cohort of patients to go through. And just a very quick review of this, but in our centre we've trained over 30 fellows in ultrasound guided biopsy, and not every fellow, not every 30 of those fellows has undergone such a rigorous training program. But if they stay with us for a number of months, what happens is they're given training in ultrasound guided injections and ultrasound over about 2 to 3 months. They then have an observing time where they observe the fellows doing the ultrasound guided biopsies, generally about 1 to 2 procedures. And when they feel comfortable with that, they then have these supervised procedures, which is generally about 10 under supervision before they're independent practitioners for each of the individual joints. The main joints that we biopsy are knee, wrist, and MCP. And what Alessandra has looked at is the 298 procedures that were performed in our department by these trainees and compared them to 2 experts within our department who have been doing biopsies for a number of years. And again, Lauren's going to present this data in the context of, again, a collaborative effort through the European Synovitis group. But just to briefly summarise what Ali's demonstrated within our unit, it's essentially with training, the number of graded synovial tissue fragments goes up, which is good because it would be a real problem if it started going down. And also, the other thing is procedure duration goes down. And you can see the massive variation in that. So when you initially start doing ultrasound-guided biopsies, it'll take over an hour, sometimes an hour and a half to do this. But somebody who's been doing it for a while, it'll take 20 minutes in and out, very, very quick. So I'll let Lauren elaborate on this later on. I haven't really got the hang of this. Oh. There we go. So the final, final point I wanted to bring up is this outstanding issue to be addressed, and that's the performance of these biopsy techniques within a multi-centre clinical trial, which is one of the filters under feasibility in the OMERACT validation process. And a number of you who come to the European Synovitis group have seen this slide on a number of occasions before, and many of you are collaborators on these studies. But for those of you who don't, in London at Barts in London, we've been running 2 biopsy-based randomised controlled trials for the past 5 years, I think it is now. The first of which is R4RA, so that's the mechanisms for response relapse resistant to rituximab in RA, where patients undergo a synovial biopsy and then are randomised to rituximab or tocilizumab. And we're looking at predictors of response to either of these drugs. We've had it was a multicenter study across Europe, and 238 synovial biopsies were performed on 164 patients. And the study completed to target last December. We hope to have last patient, last visit in December of this year. So we'd be not only hope to report the results on outcome in terms of clinical measures, but also on how the biopsy techniques performed, because we have robust data on quality of the synovial tissue, but also tolerability data for, within this study. And this includes patients who are biopsied using arthroscopy and both ultrasound-guided techniques. We also have the STRAP study, which is again is a biopsy-based study, but at an earlier disease stage for patients with rheumatoid who have a DMARD inadequate response. And patients are randomised to rituximab, etanercept or tocilizumab, and then followed for 12 months, again looking at response. We haven't finished this study yet. We're still looking for patients. We've now spread it out to the EU. We're up to about 158 patients at the last count, of a target of around 200. But again, this study will close towards the end of this year. And again, this will give us a really powerful cohort to examine these tolerability issues and the quality of the tissue that we're getting within, you can see the number of centres that we have in these studies. So, as a summary, where are we at the moment? Well, I think we have these 4 techniques. We've got arthroscopic, we've got 2 ultrasound-guided procedures, and we've got blind needle. I think we know from the comparative data so far that we have really good success rates for sampling for both arthroscopic and ultrasound-guided, slightly less so for blind needle. Generally, the ultrasound-guided procedure is seen as technically more simple than arthroscopic. They're all pretty acceptable to patients, whichever study you look at, and the comparative studies that we have would indicate that they're all patient-friendly. One thing to note, however, is that if you're looking for a study that needs serial biopsies, I would argue that the arthroscopic and the ultrasound-guided needle approaches are the ones to look for, because using a portal and forceps or a blind needle is very difficult in an uninflamed joint. So I think Doug covered major research outcomes pretty nicely, and this is a paper that he was senior author on as well, which also summarised it very nicely and led by Carl Orr. But I think it was a beautiful paper, and I think this table summarised why we get so excited about how we've got to push forward our synovial biopsy research and increase active access, because there have been fundamental moves forward in our understanding of both the pathogenesis of rheumatoid arthritis, to identification of biomarkers of early arthritis, and response to treatment over the years, particularly synovial macrophages that Doug mentioned already. But one of our problems is that at the moment we're not translating that research into a test that we can use by the bedside in the clinic. And we still have issues with patients with rheumatoid arthritis. You still see a patient in clinic, and often you can sort of flip a coin as to how that patient's going to respond to methotrexate, and indeed how they're going to look in 12 months' time, whether they're going to be on a biologic or whether they're actually going to be doing really well and just needing a bit of hydroxychloroquine. And just to finish, I just wanted to mention some data that we have looking at this, which has emerged from our pathobiology of early arthritis cohort, which is a study that's been running for the past 10 years in our centre. We've now recruited 330 patients, all of which have had this baseline synovial biopsy. along with clinical assessment, and had followed for 12 months. We've got defined robust outcomes, including clinical assessment and radiographic data. And this is just data that we've just submitted from the first 144 patients, which are generally representative of an early RA cohort, with the majority being seropositive. And our observations from this are that these patients generally group into one of three pathotypes, so these distinct groupings of infiltrate of immune cells, which are again associated with specific molecular profiles. And interestingly, when we categorize patients and stratify according to these synovial pathotypes and look at significant differences in clinical parameters, what we see is that particularly within the lymphoid pathotype, which are those patients with a dense B-cell infiltrate, we're seeing higher levels of inflammation and more disease activity. And just to summarise our results very briefly, what we see at 12 months is that these patients with this lymphoid, with this dense B-cell infiltrate, go on to have the worst radiographic damage. And this can be incorporated into a prediction model, which is shown here, which if we take clinical variables and then a number of the genes which are upregulated in these lymphoid patients that go on to progress, we can reliably predict at baseline which patients are going to do worse. So, as a summary, I would say synovial tissue is becoming increasingly accessible. And we are beginning to define the limits of each procedure, and that enables us to optimise our choice for specific clinical trial protocols. We're also beginning to define training requirements for these minimally invasive ultrasound-guided procedures, and hopefully, imminently, this will lead to the translation of this research to routine clinical care. This aim is a very, I don't know whether it's overused at the moment, but it's, we do aim for personalised medicine in rheumatoid arthritis. So just thanks to our clinical team at Barts in the London, Professor Salis, of course, who leads our group, our lab team, and actually all our collaborators, particularly through the European Synovitis group, who've contributed to an enormous data to a number of those studies that I've presented there. Thank you.